Marble, I got the hell communication. Marble, keep it on and on.
On and on.
Episode 28.
Dr. Amesh Adalja coming at you. Check it out.
Yeah.
Welcome to Solving Healthcare. I'm Kwadwo Kyeremanteng. I'm an ICU and palliative care physician here in Ottawa and the founder of Resource Optimization Network. We are on a mission to transform healthcare in Canada. I'm going to talk with physicians, nurses, administrators, patients and their families because inefficiencies, overwork, and overcrowding affects us all. I believe it's time for a better healthcare system that's more cost-effective, dignified, and just for everyone involved. Welcome back, everybody. Quadcast still representing. I hope you guys are staying sane, doing your social distancing, physical distancing part to combat COVID-19. And thanks for listening, everybody. I am super stoked to tell you about our episode with Dr. Adalja. We cover all things COVID. For example, how is it transmitted? You're hearing a lot of controversies on whether we should be wearing masks in society. For example, what's the reliability of our tests? What's the overall landscape of COVID-19 right now, especially where he is in the United States? We talk about how we reintegrate into society. He has a great article out in Medium that was in late March that kind of outlined what are the steps we really need to do to be able to get back to society as we know how. And also, like, what's the timing? Like, how far off are we from reintegrating into society? So excellent conversation with Dr. Adalja. Before jumping into it, let me tell you about our sponsors, Audible.ca. I'm telling you, Audible changed my game. Being able to listen to books on the go, you could adjust the speed. I listen to my books at 1.5 to double speed just to be able to go through that many more books. Improve knowledge, improve game, all for a reasonable price. Use the sign-up code attached to the show notes and you get your first month free. Game changing. Second sponsor, BetterHelp, online counseling service that provides reliable, efficient, convenient counseling at your disposal. Times like this when we're all stressed, social isolation, it's tough. So, these guys are excellent. Use the promo code Solving Healthcare and get 10% off sign-up fees. One last housekeeping item. We just started to do webinars specifically on COVID-related issues for now, just to be able to provide that much more information for clinicians and people on the front lines, and also to be able to ask questions to the experts. And so look for sign-up opportunities on our social media posts, whether that's Twitter, Instagram, Facebook page. And on the show notes, you'll see something. We'll also have an ability for you guys to sign up for our webinars. Right now, we'll probably be aiming to do them every 1 to 2 weeks. We'll see how the uptake is. And please provide feedback if you find it useful or not. Our whole goal is for us to be able to change the boogie, inform our clinicians and the public on how we could combat this thing. So please let us know. Okay, let me tell you about Amesh Adalja. He is an infectious disease specialist at Johns Hopkins University Center for Health Security. His focus is on emerging infectious diseases, pandemic preparedness, and biosecurity. He's worked on U.S. government panels to decide on guidelines for treatment of plague, botulism, and anthrax. You may have seen him on MSNBC and on CNN talking about our preparedness for COVID-19. This guy's a hustler, and he's knowledgeable, and I'm so excited to bring him on the show. So without further ado, Dr. Adalja. Ladies and gentlemen, we have Dr. Amesh Adalja, infectious disease specialist from Johns Hopkins. We are so privileged to have you on the show. Thanks for joining us.
Thanks for inviting me.
Yeah, and I got to tell you, people, my friend here has been hustling. I think this is April 10th, and I think it's 9:00, and I think he's already made an appearance on MSNBC and CNN. So I really appreciate you taking the time. First question I got for you is, I want to hear your perspective on transmission of COVID-19, because we hear all these different approaches in terms of should the public be wearing masks? How extensive or how transmissible is COVID-19? So as an expert in the field, I'd love to hear your perspective on this.
Sure. So what we know about COVID-19 is this is a coronavirus, and coronavirus is spread through the respiratory route primarily. That means coughs and sneezes that go from one person to another, or maybe the coughs and sneezes land on a surface, or they land on somebody else, and they can actually transmit that way. So this is called droplet transmission, where a particle maybe travels 3 to 6 feet before it falls to the ground by the action of gravity. And it can also live it can be viable on surfaces. Some other transmission that you might have heard about is called aerosol or airborne transmission. And that's something that's characteristic of a virus like measles, where the air itself is infectious for hours after somebody has left that place. What we've seen here is that with the coronavirus is there are some experiments that show aerosolization is possible when people cough or when people breathe or when they sing, for example, and definitely in hospital situations. But it's hard to quantify if that's actually happening in the community, because if you look at the epidemiology, meaning the number of cases that we're seeing and who's getting infected, it doesn't appear to be spreading like an airborne virus. But we do take precautions in a hospital because certain procedures where you're manipulating someone's airway or putting them on a certain type of machine, a mechanical ventilator or a BiPAP machine, or suctioning them or doing a bronchoscopy, all of those are called aerosol generating procedures, and there's heightened protections. But in my analysis, I don't think that there is much airborne transmission going on outside of those special healthcare settings.
Okay. And so a couple questions. So when we talk about a droplet from a patient or a person that sneezes or what have you, and it can land on surfaces, how long do you think that you could still contract COVID when it's on the surface?
So you'll find articles in lab studies where you can see the virus remaining viable on certain surfaces for several days. But it's important to remember that in those lab studies, everything is perfect in terms of the humidity, the UV exposure, the temperature, and the surface. So what I think in most everyday situations, this virus isn't going to remain viable for less than a day on most surfaces, or for more than a day on most surfaces. And I think that there's certain surfaces like kitchen counters and desks and household items that are definitely vehicles for spread. I don't know what proportion of spread occurs by these types of interactions versus person-to-person interaction. But then there's lots of scenarios people can dream up where they're worried about their mail or they're worried about their groceries, where I don't think there's a real transmission risk in the same sense as your kitchen counter.
Awesome. Excellent. And so we're going to get into a little bit about how we reintegrate into society, but maybe we could speak to about how the general public could reduce their risk of acquiring COVID-19. Like we're in an era, obviously, right now where we're doing our physical isolation. As I mentioned, it is April 10th. But what are other common measures people could be doing?
So in terms of reentering society, or just now?
Just now, in terms of, like, I'm alluding to like the hand washing and the mask kind of approach.
Right, sure. So what we're doing now basically is social distancing and hand washing and trying to tell people to avoid touching their face and cleaning down surfaces. And what these are very blunt tools because we don't have an antiviral, we don't have a vaccine. So this is the only way you can really interfere with the disease transmission. One other thing that's somewhat controversial is you're seeing the use of masks, which had been very common in some certain parts of the world, but in the United States, for example, there were recommendations for the general public not to wear these masks. And now you're seeing a new CDC recommendation advising people wear homemade masks. And what that's based on is an idea that there are individuals who have the virus but have no symptoms at all, and they may be able to transmit it through their coughing and through even without coughing or sneezing, but through their normal everyday talking to other people. And what that mask is supposed to do is serve as a physical barrier for those droplets that maybe come out of people's mouths when they talk. And this is somewhat controversial, and there's no clear evidence that wearing these masks is actually beneficial. And there are some studies that show that wearing a cloth mask does not stop the droplets that much from coming out of your mouth. So this is something that the CDC has recommended and certain people are wearing as another measure. It's not necessarily to protect the wearer from getting infected, but to protect other people from being hit with droplets from the wearer. And I'm not sure that there's enough data to say that that actually works, yet it's become a recommendation. In my own practice, I'm wearing a mask when I'm seeing patients or when I'm in a healthcare facility, but I'm not wearing a mask when I'm out in the general public at this time.
Yeah, that was going to be my follow-up question of what how you're handling it. And my practice is the same. You know, after reading that Tugwande article, especially within hospital, making sure that, you know, I'm masked up anywhere in patient, especially during patient encounters. So important there. So why don't we dive into like how we reintegrate into society? I mean, that article that you published in Medium late March really inspired me because it was not just doom and gloom and what we're up against. It's how do we overcome? How do we get back to society? Because, you know, we had Paul Offit on a couple of weeks back, and he talked about, you know, what are these risks of a prolonged social isolation period, not only on the economy, but also like on the healthcare system in general. Patients are going to unfortunately have to suffer, you know, elective surgeries aren't happening, mental illness increasing. So from your perspective, how do we get back to society?
First, I think you really have to think about this from a philosophical standpoint and realize that we've got two major things going on. We've got a virus that's spreading that has the potential to collapse hospital systems and lead to death and suffering, and it's contagious from person to person, and we have no tools against it except for social distancing. And on the other, we have to realize that having a functioning society with an economy that's moving, where people are earning their livelihoods, where people are able to do things that they enjoy, and that they're able to get care for all of their healthcare needs. Both of those things are true. And there's got to be a balance between trying to keep this virus at bay and not have our healthcare systems inundated on the one hand, and allowing people to be able to flourish as well as have their other healthcare needs met. And I do think that there isn't much balancing going on, at least at the early stages of these economic shutdowns, where everything was solidly focused on COVID-19, and rightly so, but there was too little attention paid to what the long-term consequences would be to economic shutdowns and how to think about other healthcare needs and what exactly is an elective surgery and what exactly is a life-sustaining business versus a non-life-sustaining business. None of that was really a part of the consideration. I think now, as we see curves flattening in New York and California and Seattle, you are seeing people start to talk about this. But that's what we have to do, is because the longer you have an economic shutdown, the more the costs are going to rise. And these are not just economic costs. These are people's livelihoods, their psychological well-being, and their other medical conditions. We know that people have elective procedures scheduled or trying to schedule them. And elective doesn't mean they're going to get a nose job or cosmetic surgery. Elective means you've got some flexibility in scheduling something, not infinite flexibility. So if you're talking about a cancer screening colonoscopy, you need to do that at a certain time period for it to be effective. The same is true for biopsies. And there are other conditions, for example, psychiatric conditions, which I've personally seen people have exacerbations of because they couldn't get to group therapy, because group therapy was canceled because of social distancing. We're seeing alcohol consumption increase. So all of these types of things have to be weighed against COVID-19. And I think that sometimes that doesn't happen. And I'm an infectious disease doctor who warned about pandemics, who knew that there were consequences like this that would happen. So it's not like I'm trying to say that we let COVID-19 run rampant, because we can't do that either. It's just that this is a very complicated decision, and there's not a false alternative between doing everything as we did in December and January versus allowing the virus to run, versus locking down in a Wuhan style lockdown, because that's all that matters, without caring about what the other costs are. So exactly. I do think we need to start looking at businesses that are closed and thinking about which ones can be open, what modifications might need to be done to for social distancing, and at the same time making sure hospital capacity has been augmented, diagnostic testing is intact, and then you have to really think about high-risk individuals and make sure that they have certain guidance for their own social distancing, which may be more rigorous than what the general public does. Mm-hmm. There's ways to move forward here and have the best of have a degree of control that's manageable of this virus on the one hand, as well as having some economic activity that allows people to live.
Mm-hmm. So, and I totally agree, because, it's a conversation I think that we're not having enough, but I'm glad to hear that, it's starting to make, this is starting to be addressed. So when we think about how to approach this, what are some of the things that we need to do? For example, testing, in terms of, do you think we need to have immunologic capacity in terms of our testing, or what scale or level of testing do we need to be doing? Do you feel like, for example, if you've been exposed, do you think is evidence suggesting that you're immune so that maybe you can re-enter the workforce? Any thoughts on that?
Sure. So we do need to do much more testing than we're doing now, and that includes diagnostic testing of individuals who are sick, as well as antibody or serological testing to see who has been sick and to try and assess immunity. So we don't need to test every person in every country, but we need to have the ability to at least know what's going on in any community and have that influence how we handle social distancing. Mm-hmm. So if a community has a high prevalence of disease of recovered patients, it's much more different than some place where the virus has not been. And you can have different social distancing policies based on that. And I do think that we still need to understand what antibodies mean, how durable they are, what level of antibodies confer protection, and how much protection do they confer? Do they confer protection from reinfection or just from being symptomatic again? Mm-hmm. And are you contagious if you are just reinfected without symptoms in the presence of antibodies?
Right.
And we also need to be able to test we need to have rapid tests for people who have symptoms. We need to be able to know all of this very quickly and easily. It needs to be seamless, like an HIV test. Right now, there's still bureaucracy. There's still worry about supplies for the test, reagents, and nasal swabs, that people are refraining from testing everybody. I know in my own practice, I'm not testing probably just as many people as I am testing. Mm-hmm. And I'm especially not testing people with mild patients or patients that I'm not going to be that are not going to be admitted.
Yeah, because that's a great point too in terms of the testing. Oh my God, Marlo. Sorry about that. The availability of testing. This is a big concern, for us, and also the turnaround time for testing. So for example, at your sites, what is the testing process?
So I'm on staff at a couple of different hospitals, and just to be clear, although I work at a think tank at Hopkins, I work clinically in the Pittsburgh area in Pennsylvania. Mm-hmm. So I'm on staff at some hospitals here, and it varies from place to place. But I would say in most situations, there is some kind of adjudication that's made that you have to decide. You or one hospital, there's kind of a team, a hotline that you call, and they decide if a person merits a test or not, and that has to do with their symptoms, if they're being admitted or not, and what their profession might be, because healthcare workers have a lower threshold to be tested.
Right.
And then you do the test swab, and then in some places we do still test for respiratory viruses, other respiratory viruses, mm-hmm. and some places you don't. And then the coronavirus test is done usually off of the same swab. Mm-hmm. The turnaround time can vary between a day or, in some places, 2 to 3 days, depending upon if the hospital's sending it out or doing it in-house. Mm-hmm. And that's too long, because we have to keep those patients in isolation if they're 100%. Admitted, or if people go outside, if people leave, if people go home, they're kind of in limbo for a couple of days without really a good action plan for what to do. So these turnaround times ideally should be, like what we're hearing with the rapid test, within 15 minutes, that we should be able to know, just like we do for an HIV test. But unfortunately, although those tests are around, they're not highly available at every hospital. And I think that that's really what we need to get to eventually to be able to have a really proper ability to control this virus completely.
And do you have a sense of how far away we are from being able to have access to such technology?
Well, the technology is there. For example, the Abbott test has been given FDA emergency use authorization, so it's there, and some places have it. It's just not every place that has it, and that's the issue, is getting that production ramped up of this type of technology so that it can be in every hospital, every doctor's office, every emergency department, every urgent care clinic, and then you can really have a policy that makes testing so simple that you have a lot more situational awareness of what the virus is doing in your community, and then you couple that with antibody testing to see who's been infected in the past, and then you can really have a perfect picture of what's going on in your community, and then make a lot of decisions based on that information. I think, unfortunately, we're not going to get there soon. We're going to have to be making decisions without all of that, because I do think that we're now kind of getting close to a point where they're going to have to start making decisions about what social distancing recommendations are effective, which ones are not effective, what can be lifted and loosened, what can't be lifted and loosened. So we're going to be doing that, I think, imminently in many parts of the world.
Yeah. So just to reinforce, like, basically the technology is there, as you mentioned. It's just not available to all. You don't see it being available to all in the near future, whether that's rapid testing, antibody serology, but we're going to have to make some decisions based on, the tests that we have available to us now. Yeah, it's such tough times and so many tough decisions that are going to have to be made soon. Do you get a sense of, like, one of the common issues that we have in our hospital is how reliable our testing is? I'm wondering if you could comment on, when you have a negative test, for example, like, how confident are you that you're truly negative? And if you're, for example, negative and you believe it, like, at what point can you, no longer, for example, be in a COVID ward, for example?
So this is a hard question, and I do think that there is a question about false negatives. So false negatives happen with every test, and especially with respiratory viral tests, we worry about, for example, was the specimen adequate? Because it often involves a nasopharyngeal swab, and that swab, how far that goes back in someone's nose, that's all operator dependent, and we often wonder, was the specimen adequate? The other question is the other issue is that people do have a differing viral loads, and all tests have thresholds. So you can test too early or test at a point where the viral load is below a threshold, and it will be called a negative. And then there's sometimes discrepancy between upper respiratory tract samples, like the nasal swab, and a lower respiratory tract sample, like sputum. And there one can be positive and one can be negative. So those are all of those limitations. And so I would say that there is some concern for false negatives. I don't think we as a healthcare community have actually addressed that, trying to understand what a false negative is, because there are patients that I've seen that I thought would be positive, almost certain would be positive, which were negative. And based on some hospital policy, they do sometimes go out of the COVID units or go out of isolation. And that does pose a risk to healthcare providers as well as to other patients if they are truly positive, but the test was negative. And I do think that we're going to have to get better at thinking about this as we get more and more patients and as we have to deal with this on a day-to-day basis in the foreseeable future. And the other thing is if you have an alternative explanation, then I'm much more likely to believe the negative test, meaning that they didn't really fit the picture and now you've cultured a bacteria. So there are patients like that as well, or that they might have been having their shortness of breath may have been coming from a cardiac issue and not from an infectious issue. So I think you have to kind of interpret the test in light of the patient as a whole.
Yeah, it's so complex, and thanks for clarifying some of these concerns, because at our sites, it's definitely something that's constantly evolving, and it's also based on the amount of patients that we're seeing that are suspected of COVID-19. But yeah, it's a true challenge. Are there any treatments that you hear about that you're optimistic about? Because I think this is something that's also going to play into how we can get back to normal society again. because you'll hear some talk about a vaccine, which personally, I don't think that's a realistic option in the near future. But yeah, I'm wondering if you could comment on anything that you feel optimistic about, or if you feel like, this is all kind of, pipe dream stuff.
I am optimistic about antiviral therapies. We do have multiple antiviral therapies in clinical trials, as well as some repurposed drugs like hydroxychloroquine, which you hear about. But I do think that we will likely have an antiviral. But it's important to remember that an antiviral is not a panacea, and maybe something that is used in the hospital to decrease rates of mortality or decrease rates of being needed to be put on a ventilator. It may be something that you use in high-risk patients to avoid them getting pneumonia, but it's still not going to decrease the transmissibility that much of the virus. I don't think that there is a Tamiflu right now on the horizon, but there are in the farther back if you look in the horizon. So I do think that these are going to be important tools that we have to use on patients, but I don't think it's going to be something that changes people's total risk perception of this, because they're going to really be using the critically ill patients, and that's a very small number of them. So the main issue still is going to be hospital capacity. I don't know that the drugs will preserve hospital capacity. I think a vaccine will do that, and I think the most optimistic estimates are 12 to 18 months. So we're going to be battling this virus for some time without a vaccine.
What, and in terms of I forgot the term, covalent antibodies, have you had much reading about that? Or
yes, there are efforts to do what's called convalescent sera, which has antibodies. So if a person recovers from this infection, they have antibodies in their blood that could presumably be effective in another patient. So there are efforts underway, and there had been already in China, to collect the blood of survivors and use that plasma on individuals who are sick with the virus to see if there is a beneficial effect. And that's been those clinical trials are being set up now in the United States, and they'd already went on in China, and there's some anecdotal positive evidence coming from China that this was effective.
So some stuff down the pipeline, nothing making you scream of optimism yet, but the real helpful tool will be a vaccine, but we're some steps away.
Right. It's not that I'm not optimistic about antivirals. I just think that they're still not going to, they're going to be part of the solution. They're not the full solution.
And I don't know if this is a fair question for you or not, but have you, one of the things that, to get us back to a society is knowing who's at highest risk of getting sick from COVID-19, not only acquiring it, but getting sick of it. Because I think, we realize how contagious and infectious it is. In your practice or in your literature, in the literature, have you found there's patient groups specifically at highest risk? Because the reason I think this is important to think about is because, as you mentioned, if we could focus some of our isolation measures or preventative measures on specific groups, maybe this will allow for more quicker integration into society.
Right now, we have a lot of data that shows that there are individuals that are at higher risk, but we don't know exactly how much each of these specific risk factors confers risk. So we know that each advancing decade of life has an increased rate of hospitalization and death. We know that comorbid conditions like diabetes, high blood pressure, obesity, all contribute, as well as lung disease and immunosuppressive conditions. But we don't have any granularity on exactly what the odds ratio is of, for example, of having to be hospitalized if you have diabetes versus not. We don't have that type of data, at least yet. I think that we're getting, you could probably calculate all of that. So I do think it's just kind of now a general recommendation or admonition to those people with medical conditions or with advanced age that they're the ones that are at highest risk. And I do think that you're going to see social distancing, even when it is relaxed, to still be something recommended for those high-risk groups as much as possible.
Amesh, I'm cognizant of the time, so I want to ask you, might be a tough question, but I think it will just give us a sense of what your thoughts are. How do you see this playing out? Really, how do you see it playing out? Whether you want to speak specifically in your area or in the country in terms of, is when the curve flattens, how we reintegrate, is there going to be a resurgence in the fall, in your opinion? How do you see us really getting through this?
I do think that this is going to be a seasonal coronavirus, meaning that it's going to be with us. I don't know that we'll get full seasonality in this summer coming up in the Northern Hemisphere, because even though the virus has difficulties being viable on surfaces during summer and hot months, there's still so many people that are going to be susceptible to the virus. That person-to-person spread may still occur to some degree during the summer. But I do think it's going to be something that's with us in the human species, like 4 of the other coronaviruses that cause about 25% of our common colds. Mm-hmm. So this is something that we're going to have until we have a vaccine. I do think that there's going to be a change in risk perception among the public and among policymakers as we see that hospitals are able to, with help, meet the capacity needs that they have with the medical surge that they're getting of patients. And that's going to allow us to probably relax some of the social distancing recommendations, some of the more extreme economic shutdowns, because, like I said, more and more people are going to be able to quantify the cost of these economic shutdowns in terms of the economic consequences, as well as the life consequences that people are having, and the other medical conditions that are really going to have a measurable bump sometime in the future because of what was not happening during this time. So I do think we are going to get to a place that we sort of live with this virus and have some containment measures in place or some mitigation in place, but allow the rest of the economy to work. I do think that there are going to be some issues with, for example, mass gatherings and trying to find a way to do that safely. And that may be something that may really only come back in earnest after we have a vaccination available, because it may be that any mass gathering would be too much for any healthcare system to handle if it led to a major influx of patients. And I think that's going to be maybe geographic maybe it's going to vary geographically by city on whether or not mass gatherings are allowed. And the same is true for professional sports, how that would be modified, or movie theaters or Broadway shows. All of that, I think, has to, there's going to be decisions and discussions about that. But I do think in general that we will start to see lifting of the economic shutdowns in the near future.
And do you think people will be able to, like from a healthcare system's point of view, will be able to manage? Do you think healthcare providers will be able to protect themselves with all these concerns of, are we going to have enough PPE and all those considerations?
That's also, when I think about what will help us guide our social distancing, one of the biggest conditions is the level of hospital preparation. Do hospitals have enough ICU beds, ventilators, staff, as well as the personal protective equipment? That has to all be intact, because if you do get a surge and people are not able to be taken care of appropriately, it's just going to magnify this. So we know that this will probably, as you start to relax social distancing, you're going to see cases get an uptick, and you want that uptick to be at a manageable clip for hospitals to be able to handle. And as part of that, they have to be adequately resourced, including having a durable supply of personal protective equipment where they're not worried about that supply.
Yeah, so that's part of the equation. And in your world, are you guys, like, I know you're at multiple sites, but how are you guys doing now?
At the hospitals that I'm on staff at, I've had no problems with personal protective equipment. Like I said, I practice in the Pittsburgh area, and while we have over 100 people hospitalized in the city, in the city and surrounding suburbs, we haven't been hit with a major surge. We've not seen any kind of issue with patient care being compromised or personal protective equipment issues. So I think that at least in the area of Western Pennsylvania where I practice, we seem to be handling this very well. And we're supposed to get a peak early, according to some models. So hopefully we'll get through the worst of it. And I think Pittsburgh isn't going to have a discrete spike the way New York City did. It may be more of a rolling number of cases that stay below hospital capacity, hopefully because of the changes in the preparations we've made here.
That sounds similar. Well, first of all, go Steelers. Second of all, that sounds like a similar situation that we're in up in Ottawa. Like we've been saying that the surge should happen weeks ago. It said any time now. And, our ICU capacity, we have room. We're not being overrun. Our hospital's relatively empty compared to normal. Emergency rooms are empty. So, maybe this is doable, Time will tell.
Yeah, I'm increasingly optimistic about many parts of at least North America's ability to cope with this, especially when I'm in the hospital and talking to people, clinicians like yourself. And sometimes you can get dismayed when you're talking to only public health people. So I think sometimes it's good to have clinicians talking about it because we're actually seeing what's going on the ground versus staring at models.
100%. Because, I've recently been on our local news talking about, why there's reason to be positive at this time. Like we've, at least in Canada, we knew about this early. We've enforced early physical isolation. We have excellent public health, and right now we're coping. And I just, it's a lot of doom and gloom when you go on social media or just conventional media. And maybe the last thing I want to say is, and maybe I should have started with this, Amesh, is how are you doing? Like you're hustling. You're, like I said before, you're doing the social media stuff, which is great. You're doing CNN. You're spreading the word about how to combat COVID-19, but and you're on front lines. So like how are you doing yourself?
I'm doing well. I think that it's been a challenge to balance everything and to decide where my time is most valuable. I've been trying to do as much as I can, and it does take its toll in terms of lack of sleep and being tired. But I'm making it through it, and I think it's in the very beginning of this outbreak, I was, it's quite overwhelming. But I've had some ability to be able to manage my time a little bit better and gain some perspective on how to do this, because this isn't going away, and this is something that I'm going to have to deal with in all of its facets for some period of time with the career I've chosen. So that's something I've gotten to be able to manage somewhat better, but it is going to be challenging for the next several months for sure.
Mm-hmm. Yeah. And we all been preaching to each other, we got to pace ourselves because, as you mentioned, it's a long road ahead. But your work that you're doing, I got to tell you, super important, super valuable. We're appreciative of it. We are appreciative of you taking the time to teach us all about COVID-19 and with your level of expertise. And, love to have you on again. Really appreciate you taking the time, bud.
Sure. Thanks for having me.
Absolutely. Take care. All right. Thanks everybody for listening to our conversation with Dr. Amesh Adalja. I hope that was useful for you guys. Please leave any comments at quadcast99@gmail.com. Follow us on Twitter, Instagram, YouTube at Quadcast. Please don't hesitate to subscribe, whether it's on iTunes, Apple Podcasts, Spotify. We really appreciate your support. Leave a 5-star rating if you're up to it. I want to thank our sponsors, BetterHelp and Audible, for their support. As you may have seen, we're continuing to do some webinars on not just COVID-19 content, but other content, just to give you an opportunity for some Q&A. So stay tuned for that. Please sign up when available. I want to thank our team at Solving Healthcare, continuing to produce amazing show notes. We're going to start a newsletter soon. Social media team, we really appreciate the work that you guys are doing. Quadcast listeners, stay healthy, stay home, and remember, we'll get through this. Take care, everybody.